Welcome back to the PHAF webinar of November. In this, we are going to see that pain management and how we are going to balance the risks and benefits. Before entering into the proper pain management sheet, we should first see that what are the major risks because of the treatment or some management drugs, and from that, opioid is on top. So we are going to first see that what actually that opioid is causing the problem and how severe this problem has become in front of the world now, and how we are now suffering with the lots of problems due to the uh, addictions or abuse of the opioids. So we are going to see this and opioids first, and then we will move towards the pain, types of pains, and how and which all factors are going to affect the pain management, and more on that. So let us start with the first section of this discussion. The use of opioid analgesics has increased dramatically along with the rate of deaths due to the opioid overdose. Opioid-related overdose deaths were 5 times higher in 2017 than in 1999, which is really a high number, which is about 218,000 opioid-related deaths due to the overdose. And that is only just data of United States, so you can imagine the all over the world what can be the death rate. And this is data only between the time duration of 1999 and 2017. While there has been decrease in opioid prescribing, there has been a reduction in the opioid prescriptions since 2012. But if you see that the death level, it is increasing. Uh, So as compared to the prescribed medicine, the death is increasing. So that is clearly showing that if we limit the prescription, if we limit the prescribed opioids, it does not the complete solution for the opioid crisis. As you can see here, the prescription is going down, number of prescription is going down. But if you see that death, opioid related death is going high. That is clear indication that prescription is not at all, we can say that the prescription is not responsible. And if I want to get out of this crisis, a part of prescription, I should take care of few things, that is addiction and as well as abuse. Now, the highest increase in opioid health deaths has occurred due to the fentanyl or fentanyl analogs, and in that mostly it is carfentanil, which the use of carfentanil, you can't even imagine, it has increased about 540% in 3 years. So that is really a very huge number. 540% is that's a really huge number. Mostly opioids are prescribed in the form of patches or lozenges, and this prescriptions are getting misused or getting abused. If you see that potency of that carfentanil just need to be 10,000 times more potent than morphine. And by this only we can assume that how dangerous it can be or how it can be deadly to take overdose of carfentanil. Or you can say that due to the abuse of carfentanil, the death rate has become very high. Now, if I try to manage this overdose toxicity, the most challenging is that I have to give very higher or repeated dose of naloxone, and that also in higher dose as well as repeated dose. repeated doses are required to reverse this overdose of fentanyl. Codeines, hydrocodone, combination products, oxycodone, fentanyl, morphine, hydromorphone are all Schedule 2 controlled substances. These agents carry the risk of abuse and which can lead to the psychological and physical dependence. This can have the psychological or physical dependence, and all clinicians, before going for the treatment with the opioids and all, we should be aware that what are the risks and what are the benefits associated with the immediate release or extended release, or we can say that long acting opioid analgesics. We should be aware regarding the risks and benefits so that we can compare that either we should go for the opioid treatment or not, or how I can balance the risks and as well as the benefits of the opioids. To see the risks, then one is misuse, divergence can be there, or it can be addiction also. It can be abused by patients or household contacts, interactions with other medications or substances which patients may take without informing the medical practitioners, risk of neonatal abstinence syndrome, inadvertent exposures or ingestion by the household contacts, like especially children's. In case of children can take it. Life-threatening respiratory depressions can also occur, and overdose of long-acting opioid analgesics, opioids analogs can also be the one or more challenges. And while on the other hand, if we see the benefits, analgesia is a good analgesic. Reliable pain control. We are very reliable drug for the pain control. Quick action we can see. Continuous and predictable action we can have. Improved functions and improved quality of life we can observe. So, if before going for the treatment with opioids, we should consider that these are the risks which can occur, and these are the benefits of which can be there, which are there with the opioids. So, I have to balance these two, right? Either I should go with the treatment. So, it can be individualized assessment by seeing both of the parameters as the risks and benefits. So it's an individualized. It can't be that same for each and every patient. Now let's see how actually that neurotransmission of the pain occurs. When there is an injury and when somebody step on the tack, an injury occurs. And as soon as there is an injury, the tiny myelinated A delta fibers carry the impulse and different afferent neurons to a synapse in the spinal cord. At this point, the signal crosses the other side of the spinal cord and the impulse moves up the aneurospinal lateral tract of the midbrain. In midbrain, this impulse encounters periaqueductal gray matter, which then transmits the pain to the sensory cortex. The variety of neuromodulators are involved in this process. The sensation of pain in the brain is an early warning of the system for recognition of danger or any injury. In acute situations, the pain can be addressed and resolved. In other situations, pain can continue and can escalate and become chronic. In situations such as an injury, a person reacts and giving brain a counter impulse. This is body's own homeostatic regulatory mechanism, descending pathway of down regulation, and there are a variety of neurotransmitters involved in this process. Now, as we have understood that we are all how the neurotransmission occurs, we should also be aware that where all the opioid receptors are present and how this opioid is going to act. If we see that opioid receptors presence, The opioid receptors are located throughout the central nervous system, throughout the CNS it is located. You can see it is located in brain also, spinal cord also. And in brain, opioid receptors are located in the nucleus accumbens or amygdala, which with the most of the opioid receptors being located in periacquadental gray area. So transmission from these areas flows to the sensory cortex. The periaqueductal gray area is important for receiving opioid therapy of blunt of therapy to blunt the feeling of pain. Because of the dose proximity of periaqueductal gray area of the to the nucleus accumbens and amygdala, and which is also involved in the pleasure, or we can say that emotions and reward. So people who are unable to make their own endogenous opioids, fail to make their own endogenous opioids, not feel that pleasure, and that's why this opioid use increases as an addiction or as abuse. However, this could also lead to the use disorder of some individuals. These receptors are also present in gut, so it can also lead to the constipations as well in gut also. Fine. So we can see that in brain, spinal cord, and peripheral nervous system also, and as well as in gut. So because that opiates can lead to the can give the feeling of pleasure, there is a high chance that it's getting misused or it's getting abused by the patients. Now we should understand what are the types of pains. When evaluating the pains, when we are evaluating the pains, then clinicians should consider first origin, from where the pain is originated, either it is nociceptive, nociplastic, or neuropathic pain. Then second point, physician should consider that the location of the pain, either it is central or peripheral. And third, which is important, is the duration of pain, either it is acute or chronic. Neuropathic pain develops due to the lesion or disease of somatosensory nervous system. Somatosensory nerve is located in skin, muscles, joints, and fascia, with a variety of sensors that send signals to the spinal cord and eventually brain for processing. Damage to these nerves from a lesion or a disease results in altered or disordered transmission of sensory signals into the spinal cord and brain. So neuropathic pain is mostly chronic, with some extent experiencing moderate pain, while others experiencing debilitating pain. And central neuropathic pain is caused by lesion or disease of the spinal cord or brain. So as we have seen that neuropathic pain is due to the mostly the chronic pain, and it is due to the damage, or you can say alteration into the nerves located in skin, muscles, joints, fascia, or somatosensory, or you can say that somatosensory nervous system. Now, if you see the types of peripheral neuropathic pain, then it is both one we should come with us. It is post herpetic neuralgia, trigeminal neuralgia, distal polyneuropathy, and neuropathic low back pain. Now, apart of this neuropathic pain, there are some pains which will have some symptoms like neuropathic pain, but will not be exactly have the same origin or same cause. So that's why the International Association of for the Study of Pain, that is ISP, recognized that there was a need of third mechanistic descriptor of patients who are experiencing pain that is not associated with signs of neuropathy but is characterized by hypersensitivity in apparently normal tissue. If there is a hypersensitivity in the apparently normal tissue, this type of pain is named as nociplastic pain. This type of pain essentially they named it as nociplastic pain that results from altered nociception despite no clear evidence or actual or threatened tissue damage or evidence or lesion or disease. And this nociplastic pain is also a chronic pain as a neuropathic pain. Types of nociplastic pain includes fibromyalgia, irritable bowel syndrome, or complex regional pain. Now, in this diagram figure, we can see clearly that nociceptive or inflammatory pain is the response to any injury, while here the pain arises from the altered nociceptive function, that is nociplastic, while neuropathic is pain develops due to the nervous system is damaged or neural damage, and this is just a mixed type of pain because of injury or secondary effects. So if we see the nociceptive or nociceptive inflammatory pain, then it can be post-operative or sports injury or arthritis or sickle cell disease or mechanical or low back pain. While nociplastic pain, as we have seen, that fibromyalgia, irritable bowel syndrome, or non-specific low back pain. And neuropathic, as we know that it's due to the damage, so it can be post-herpetic neuralgia, trigeminal neuralgia, or distal polyneuropathy, or CRPS, or neuropathic low back pain. So today we have seen that what are the different benefits of opioids, how opioids are acting, and how it has become a very big challenge for the healthcare professionals. So if you are prescribing opioids, how it can move to the addiction and abuse, and how big that challenge is. And part of that we have seen that what are the types of the pains and which are factors